Hello, hello, and welcome everybody to another Polestar Pilates Hour. Good to have you with us. Any kind of well wishes for Hagit today? We're excited to have you on the Polestar Pilates Hour, Hagit. Good to.
Thank you very much. I'm excited too.
We have so much information to share, and I also have been away for a couple of weeks. Shelly has covered for me, and we took a couple of weeks off, so we are back. And we're back with a vengeance. It looks like we're over 5,400 people signed up for today's webinar. So thank you to everybody out there for sharing the good news, for free information to enhance your practice. And today is no exception to the rule. So as we get started with Hagit, there's just some really good information finally coming out for those of us that work with clients that have spinal deformities and scoliosis. And so, Hagit, in this world of spine deformity and intervention, you bring with you a wealth of knowledge. You're a physical therapist. You are a master practitioner of the Schroth method. You've gone through the Polestar training. That's sort of like a little added star on there that we like. And you've taught at a number of universities, one that we both have taught at a little bit in Hunter up in New York. And you continue to guest lecture all over the place. And recently you made a presentation. Where was the last present that you made this presentation recently about scoliosis?
At SOSORT, at the International Society for Scoliosis and Spinal Disorders. The yearly convention was in Boston in May.
That's awesome. So you just present. So we're getting some really fresh content. I also wanted to mention that Hagit has partnered up with Lisa Stoltz. Dr. Lisa Stoltz is a colleague of mine for decades. She was one of our first educators in Polestar and has continued to be a great influencer. And I know the two of you connected in working in the Schroth method and working in scoliosis and have just been, so I think, pioneers in laying down the groundwork for fitness and wellness professionals to be able to work safely in this realm. And I think, without going into too much detail here, is I'd like to turn the time over for you and maybe have you just jump in and talk about what you presented in Boston. So Hagit, time is yours.
Thank you. I will very good. Thank you, Melissa, for sharing. So I will try. I was intrigued by the title to get the latest on scoliosis and spinal conditions. And I really want to take a thank you note to all my colleagues. I hope we can get to most of the updates here on this presentation. But it was a really fast, amazing collaborative work on great physical therapists, instructors for yoga and Pilates, and Schroth therapists, all the people that you will see maybe later along the presentations. Everyone jumped to help us in the Pilates hour and give me in 2 days an important information summarizing really the SOSORT convention plus more from their expertise. So these are people that maybe next time they can come on your Pilates hours and they give their expertise on breathing, on hyperflexibility, and whatever you want. You have a good team next to you.
Awesome.
So I'm going to start with the presentation that Lisa and myself presented. I presented it on the name of both of us and the other authors, Meredith Weiss and Jean-Claude Demaroy. And this is called, finally, we are able to bring it out, and the paper will come hopefully in a very good peer-reviewed journal, Best Practice Fitness Exercise Guidelines for Adults with Spinal Disorders. It used to be called deformities, but the association is coming to recognize that the word deformity doesn't do any service to people, to ourselves. And the SOSO changed it from the deformities to disorders, and we are just awaiting for the SRS, the Scoliosis Research Society, to also declare that they're changing the word because it's nicer for the patient. This is basically a Delphi study, and it was designed to help clarify and simplify the decision-making process of any fitness instructor answering those questions of what fitness exercise are good for me when we have been asked by patients. And what are the guidelines? What is good for me to do? What is not good for me to do? So adult spinal disorder is a term represents abnormalities of the lumbar spine and the thoracolumbar spine that occurs in adult patients, including scoliosis and kyphosis. We know that this population next is at risk for progression, often results in pain, disability, next Melissa, pain, disability, and spinal instability. So this is it's an issue with many people and not just those who have scoliosis. Once you have decrease of your lumbar lordosis, the hollowing of the low back that allow you to stand upright, once you have the generation and listhesis, which you're going to see soon, and I'm sorry, who doesn't have something of all of that? Even myself, okay? So, right, so what can who needs to modify these exercises? Who is okay to still continue with everything meaning bending, flexion, rotation, twisting, side bending, and all the movement that we typically encourage movement. But when you have, and this is, I really want to bring as a statement, people with disorders or abnormalities or degeneration, listhesis, we're going to see soon how it looks. They are in need for care and stability ahead of time, I want to say it, and we treat them and care for them in a little modified way or more safe way. So it's going to be hard. I'm saying it. It's going to be hard for instructors who used to encourage movement, and myself too, encourage movement throughout the spine and the body. But when you have an area that you need to protect, like degeneration in the knee, if you have a severe degenerative knee, you are not going to pound on it, and you are not going to flex it, and you are going to save it from further degeneration. Please look at the spine, at this area of the lumbar, quite the same. So we are continue from that. Schwab et al. He is a spine surgeon, one of the top surgeons, was the SRS president for years. And he created from 2006 to 2013, when really the latest paper posted, a classification system, very interesting, a classification system to guide surgical decision-making, okay? It's surgical, but I'll connect it to our conservative management. Surgical decision-making specific to the adult with spinal disorder. This radiological objective that you see here, and I'll show it to you in a moment, considered to be predictors or risk factors for poor quality of life due to pain, instability, and disability. And they are known as adult spinal modifiers, okay? And while these modifiers are specific to surgical guidelines, okay, what do we use to guide our decision-making in the gym, in the clinic, and not in the OR? So what you can see here is basically, yes, the radiological modifiers that were presented a slide before, and I can take you quickly. On the left side, you see two pictures of lumbar scoliosis. The one very much on the left is an MRI showing how L2 or 3 are basically in listhesis and instability, a little bit not oriented one on top of each other. Then maybe this could be an MRI of the whole spine you see next to it on the right, which is a severe lumbar curvature. So existence of lumbar curvature is considered a risk factor for increased pain, disability due to instability. Guys, there is no other words to say. Lumbar region without ribcage support, depending only on our muscular core stability from the side, from the front, from the back, but mainly only on our stability. And we know, unfortunately, as we age, we have reduction of muscle strength. And then we need to keep more the stability. So what do? Do we want to bend this person, rotate this person, side flex to the right or to the left, and basically it creates more instability between the vertebrae. So unfortunately, this area of the lumbar that you see needs to maintain its stability. If we do not provide it clinically in exercises, choosing for them the right spinal stability program, then they will maybe, I'm just saying it, but the next step is to have a fusion. And what is a fusion? A fusion is to create stability with two rods and screws, not to allow this lumbar spine to continue and progress. And it will, because gravity wins us. Gravity is our good and bad, but in the spine is a little bit an enemy. And we need to protect the body of a person with spinal condition like that from the force of gravity. Now you can see another 3 pictures or x-rays of the other modifiers. So if a person have a lumbar scoliosis and they have PT, mean pelvic tilt backwards, you can see how this the shape of the spine is round. There's almost no hollowing and lordosis of the spine. There is a little, but the pelvis is rotated backwards. And usually it rotates backwards as a compensation to allow the person who loses its spinal erect position due to gravity. Now they need to raise their head up. And if they don't have enough strength in their back, they will rotate the pelvis back to lift the whole trunk backwards and gaze on the horizon. And if there is also such a position of the head in front, you can see it as a 17 centimeter, that is also a sign. So the doctors, the surgeons, they came up with these modifiers of risk factors. And the more you have of those in one person, the more stability you require.
And just to clarify, when you say stability, you're talking about surgical stability according to the surgeon. So the more complexity and the more compromise in the different planes of movement, the higher the risk, the more likely the surgeons are to justify a fusion to create the stability versus us doing conditioning to create the stability. Is that correct?
Right. So these x-rays, as I said, they are surgical factors. Yeah. But we want to now relate it to the clinical setting. How can a fitness instructor or someone who don't have the qualification to read x-ray, what they can see in their eyes when a person comes to their Pilates class or to the clinic, and basically say to them, okay, we need to classify you into spine stability program versus unrestricted program. What can we give you as the guidelines without the need for these x-rays? So basically we had no specific guidelines for the instructors. You can click, Melissa. SOSORT always said to remain active. Research was only on physical therapy, scoliosis specific exercise, and we didn't have fitness exercise guideline. Next, Melissa. So the purpose of this study, next, is to develop a fundamental framework and algorithm to help guide safe fitness exercise choices for adults with spinal disorder. Next, the outcome was an expert consensus. So we basically reached close to 50 experts around the world who are physical therapists, specific, not just PSCE, physical therapist, scoliosis specific exercise expert of all schools around the world, plus the leaders and therapists. And we asked them, we sent them a survey regarding fitness and what to do, what not to do, and all of that. And then we got responses, and within 2 surveys, we were able to get almost 90 to 100% consensus among the experts of how to guide people with scoliosis in the world of fitness. And this is what we're going to present. This is the distribution of the experts' responses and their training schools. Some physical therapists have multiple school training. BSPTS from Barcelona, ISST is Germany, SEAS is Italian, Lyon from France, FITS from Poland, Dobomed from Poland, and SideShift. I want to represent out of the 14-question survey, we can generalize to 4 overriding questions. Question number 1, should fitness exercise, like Pilates, yoga, whatever, be modified when someone with adult spinal disorder, like you saw before, present with radiological risk factors? Let's say, first of all, to know if you think that all these risk factors that a surgeon put, we really need to also consider in our plan of care. And next, consensus said 100% we must consider these radiological findings. Okay. Second question, if radiological next images are not available, like for people who don't read X-ray, are there any clinical tests, and this is for all the fitness people, that comparably measure the same risk factors and identified by Schwab? Consensus says yes, 100% there are clinical tests that everyone can use. So what are they? Here you can click 1, 2, and 3. Here you can see 3 clinical tests that correlates with the 3 Schwab radiological modifier that predict pain, disability, and instability in the future. The first one on the right side is called sagittal imbalance. Basically, it is placing your body next to the wall. Everyone can do that themselves, and checking what is the distance between the back of the head, C7, to the wall. And it says that if someone can check it for you with the ruler, you want it less than 7.5. If it comes to 7.5 centimeter, it tells us there is a future risk for postural, bringing this disability.
And that's about 3 inches for somebody that was measuring inches. We all should know centimeters, but some use inches, and it's about 3 inches would be that same risk factor.
Right, and you can really look at it yourself. The second one is the presence of a lumbar curve. So clinically, have your patient, every adult patient, come, have them bend forward as a practice regularly, and check, do they have lumbar curve? Even if you don't use the scoliometer, this blue level that you see on the top of the, just look and see, can I see a prominence on one side asymmetrically from the other? And the third one is a coronal imbalance. We can look at the patient. Usually they stand with a little shift, they sit with a little shift, and we can use also a plumb line or a laser line. So those 3, if someone have the 3 of them, I want to tell you 100% that you need to modify the exercise, and I'll tell you to what. If they have one or two, I think also maybe one, be a little bit cautious. But let's look at this. There are two more overriding questions. Number 3, should movement, until now, I spoke about the structure of the body. The structure. Is it forward? Is it tilted? Is it have a lumbar? This is the structure of the body. Now let's also get some movement competency and see how is that also related. Should a movement competence be considered when making fitness recommendations? Should we look, those who move well can do more, those who doesn't move well and cannot keep stability, maybe we'll put them in a more restricted program. First, we wanted to ask all the experts. And next, consensus says, yes, 100%. So how are we going to modify them? Movement competence, and 2 more next. Movement competence can be tested by either a formal test like the FMS and modified for adults, or observation of gait, activity of daily living, different things that the person can move to you in the clinic, and you with your expert eyes, and I really can say with my hand on the heart, Pilates instructors have great eyes for movement. I think even better than many PTs, I'm sorry. And then we differentiate between a competence and a challenged mover. Remember those two. Now, it could be objective / subjective. How do? Not everyone can, maybe a new grad will have a more difficult time differentiating. Maybe you will ask a friend to help you in terms of this differentiation. But I think you'll be okay. Here are our proposed fitness exercise guideline that based on movement competence, 1, and the presence of adult spine modifier, 2. So I want to say here and explain and be clear, we are combining 2 factors. 1 is the structure of the spine, the trunk, the musculoskeletal, and 2 is the capability of performing competent mobility. And they need to be melded together. So on the left, adult with modifiers, lumbar scoliosis, falling forward, say side list, those who have this modifier, verified radiologically or clinically, like I said before, and they are competent movers, they can basically start with stability program, or they should stay with stability program because they have modifiers. Those who are challenged mover, and the consensus was 81, that's interesting. Those who are challenged mover, 92% of our consensus was, they also, of course, they will need to stay with this spinal program, stability program, meaning modifiers, existence of modifiers winning over your competent mover. Doesn't matter if you move excellent, but if you are a Pilates instructor and you are my yoga teacher who wrote a book on yoga for scoliosis, but you have all the modifiers that I told you, especially if I also as a PT, I know it radiologically, I'm sorry, if you want to save your back for the future, and I see this little sign that come, you can 60 years do well, Brent, but on your 61 birthday, if something slide or move, and you could have protected it, you can protect it. So modifiers here wins. Now adult without modifiers, in the middle, and who are challenged mover. The consensus say start with spine stability program, even though you don't have modifiers, fine. but you're a challenge mover, this put you in first stability program, learn to move properly, and then you can advance to the unrestricted program as movement competence improved. And the last group on the total right, adult without modifiers, who are competent movers, good movers. The consensus says you can immediately go to unrestricted program. No problem. You don't have lumbar scoliosis. You don't have all these changes in the spine. Even you have maybe a thoracic scoliosis. Thoracic scoliosis is usually maintain itself in adulthood. The lumbar is the one who, and you can do unrestricted program.
You know, Hagi, real quick, I love this concept of the two different variables. And I'm even thinking of how could somebody out there in, movement land take a look at this same idea of competency and movement in conjunction with bone density issues, right? It's the idea of looking at an incompetent mover that has poor awareness. And I've never seen a study or a response about that. So I'm just putting it out there into the cosmos that using the framework that you used for this with the spine deformity and disabilities, looking at the competency of the mover. I do think there's like this incredible amount of awareness of when we get to areas that potentially do create a risk. And I think that's the real key. It'd be interesting to also do a survey to the competent movers with spine disorders and ask them what it is that limits their movement into certain higher risk directions, and seeing if it's what they feel in the pressure or the sensitivity or the awareness that they've gained in their own feedback, their internal feedback. So the idea is saying somebody with a high internal feedback is less likely to move into a harmful range in their spine, considering the spine disorder, versus somebody who is looking, and we do this all the time in yoga, right? People go in and take a yoga class, they want their body to look like the instructor no matter what, but they don't have the awareness or the mobility to do it. So they then put themselves at harm. So I love this thing. You can keep going. I just wanted to interject there that
yes, no, actually what you say bring me to say, Brent, it's excellent. And it's excellent, I'll tell you why, because it brings me to say, you are, I want to say we are naive, me too, naive to think that even people, and excuse me, that have competent, and they are great in the movement, and they are great in their mind, and they know the pathology, Brent, they don't believe, they don't understand, they question, they don't believe how I cannot do anymore reaching, lying, sitting on the ground and reaching forward and lengthening my spine and rounding my spine. But this gives me the best relief. Brent, I'm telling you, this was a great one, because no, people actually need, and this is where we come. They need the instructors. They need to know it first by themselves. Two, instructors need to know that in order to deliver it to their clients, because not every clients that go to Pilates come to me, but those who come to me and I send to Pilates or yoga, I tell them, and they still, unfortunately, not listening.
We're always greater in our mind than we are in our bodies.
Right. And you know what? Maybe I don't want to say it's okay, because I know later, we know from the research, we know it was a national study about who will get surgery at the end, why they choose surgery, because they had all these modifiers and it brought them, it was a national study, it brought them into pain and disability. So let's try to avoid it a little bit before.
Yeah.
What can we tell? Sometimes
this is perfect, because I think understanding if they have the modifiers, they have the risk factors, how do we teach them and facilitate them to respect that, to have the optimal movement in their bodies for as long as they possibly can, without going down the pathway inevitably of having the pain and dysfunction associated with those pathologies. There's a quick question that came in. I think I opened up a can of worms. I don't want to go down this road too far,
Right.
but you see the question on the combination of lumbar compromises and disorders as well as bone density issues. And again, now you're having to listen to, and I don't necessarily want to go down this road unless you really want to touch it, but it's just, you have to respect the fact that there's two disorders now. One of them is an alignment disorder, and the other one is a bone density, so which heightens the risk of those particular transitional segments. And we don't have to spend time on that, but it does, you start adding comorbidities and the risk factors, you end up restricting more and more the abilities because of those risk factors. And we see that with things like, you have stenosis and bone density in an aging spine. They can't flex, they can't extend. It's like we just start respecting the whole person of what they can and can't do and what those modifiers are for them. So I don't know if you want to add anything to that. I don't want to interfere too much with what you're presenting.
You're good.
Yeah.
So we continue to present, and the final overriding question basically was adult with persistent pain, chronic pain at any time in their fitness program should consult a specialist in adult spinal disorders. And the consensus says next is 100% yes. So, and the specialist could be really, I am a big advocate nowadays about the mind and body, the soul and body pain regulation, the work of Dr. Sarno, the going inside you and try to find what brings the pain. And sometimes, it's a whole discussion about pain, where it comes from. But at least, yes, start the process of finding, is it physical, is it emotional, what can I do, and consult with a person. So in the next, this is basically, I know it's a little small maybe, and we can we can put it, we can send it out soon. But this is basically the algorithm that anyone can look. I have modifiers, I'm on the left side. I don't have modifiers, I'm on the right side. If I'm on the left with the modifiers, what kind of mover I am? Competent mover, you have modifier, you still stay in stability program. And like that, like I said it before, but there is an algorithm, and one in the clinic, every instructor can have this and go with their patient quickly and know what to do.
This is actually makes it very simple and very clear, Hagit. This is really clear to follow the algorithm. This is great.
Good.
Yeah.
So this is it regarding, you can go next to the references. And this is basically what we presented this year at the Scoliosis and Spinal Disorder Conference in Boston. And now our next is to, of course, publish the study and get it out for understanding for the population.
Awesome. The a couple of things come to my mind as you were presenting that, and I just thought, one of the most important things for us as practitioners and teachers of practitioners is trying to give them guidelines in the beginning. So when we think of a progression of novice to expert as a yoga teacher, Pilates teacher, tonic, Feldenkrais teacher, in the beginning, we need rules and algorithms to help us build the neural network of patient load, interpretation, clients, fitness programming, of how we do that. And I think that, for way too long, especially with spine disorders, we've been very unclear as a profession as what to do. Even amongst the medical professionals, you'll see them saying, don't do any of these exercises, don't exercise. And even with things like fusions or stuff like that, you'll hear them avoid any kind of movement like yoga or Pilates or gym workouts, just walk. is a common one that you'll hear from neurosurgeons and orthopedic surgeons. And so it's very nice to see work that's being done that is being supported by the experts themselves, and being able to say that, look, here are some very good guidelines for us. And this is to everybody that's listening and will listen to the recording of this, is that the more competent we become in simple assessments and looking at simple risk factors, the more positive movement experiences we're going to create for our clients. Right. And the more positive movement experiences they have, we know that leads to increased confidence, increased joy, increased fulfillment. In the ICF model, increased participation in life, increased ability to participate in activities. And I remember Lisa talking a little bit about, like, look, there's going to be people out there that have some of these markers, that they have some of these challenges, and they're going to insist on playing golf. They're going to insist on, snow skiing or doing different things that increase their risk. And I was wondering how you feel about that a little bit when we're dealing with what seems clear, at least to me right now, is the algorithm of how to say, you have these modifiers, you don't, you're competent, you're a novice. This is where we start. We go into these kind of areas. Where do you see, more on the humanistic side of it, and maybe some experiential on your part, having worked with so many individuals, when we're guiding our clients that have the belief that they should be able to participate in an activity that, according to the algorithm, would be a challenge to it? I know we don't take it away from them, but how do you communicate with clients, and especially in the fitness world, of how to create the right expectation in what we educate them about? It's like, we don't want to take things away from them. We want to empower them, but we also want them to have a spine for a long time that is not painful or disabling.
Wow, it's an excellent question. And I think when you describe it, it came to me to differentiate between sports, recreational activities that you do, and fitness 3-4 times a week that you like to do. I think we should separate the two. So both of them are for the physical and psychological benefit of the human being, and I am one of them. I was 20 years ago at HSS, when I was working at the Hospital for Special Surgery. I couldn't continue to run anymore. Take running away from me, I'm dying. So I went to, I don't want to say, I went to one of the best, first of all, in the country, sits at HSS, did an MRI for both of my knees, chondromalacia patella, meaning arthritis underneath the kneecap. And this guy is a knee specialist. And he said, Hagit, I'm really sorry. You are great, but running is not for you. Just that, running is not for you. Try to find something else. And I remember the desperation. And what? Maybe I will put a knee brace that lifts the kneecap and will not grind underneath. Maybe I will wear these braces, And then I said, you know what? Maybe I am going to start first really strengthening the correct muscle supporting the kneecap. And it's not the quadricep, as we know. It's the glute, and it's the core, and it's the foot, not just the quadriceps. And I said, I set it in my mind, and I continued to run, and it got better. And I really worked on this strengthening of the core and the buttocks. And I ran up to today, even with disc herniation, which actually today we know the discs are running is good for the disc, actually. So I understand definitely the importance and things that you can do. Now the question, people, right, with these spinal disorders, or let's say scoliosis or osteoporosis, or going to fitness, choosing, for example, yoga, general yoga in a general class with so many others around you, and not specific attention maybe to yourself. and repeating and sustaining. This is my intake. Sustaining, bending, sustaining rotation, while I know that I have a prominence on the right side, and I continue to rotate into it, or try to create more bending because my neighbors on the right, on the left are doing better bending than me. I think in this manner, I would like to guide the patient. This is the algorithm for these classes. Yeah. And going to do your sport, really, I would say once a week yoga, once a week golf, once a week tennis, twice a week tennis. First of all, I will teach them, okay, how to be stable using, let's say, my method is the short, how to be stable while you're doing your golfing and tennis and skiing. All these sports can also come from other joint mobility. Dissociate this lumbar, which anyway, honestly, between us, the lumbar facet joint are not oriented for side bending and not oriented for rotation. So the lumbar spine, anyway, all of us, I think, it's nice as we age to stabilize it. Learn to move from your shoulder joint and your chest and your breath and your hip joint.
We have a saying, right? Distribution of movement equals distribution of force. And the idea that, you've got 12 thoracic vertebrae that can facilitate you in your rotation activity. So when we look at where do most of our pathologies happen, they're happening in places that biomechanically are not inclined for those movement challenges. And I love how you, and Lisa sort of gave me the same spiel, but I wanted the guest today to hear it, is that the difference is we are fitness instructors. We are Pilates teachers, yoga teachers, gyrotonic teachers, and we have to be able to teach them according to these modifiers in those classes to give them the best possibility of participating in their life, whatever that life activity is, whether it's hiking or trying to run. And I remember a story, Hagit, very early in my career. I had a guy that was in his mid 70s and he ran every day, and he had well over a 65-degree lumbar scoliosis, but he ran every day. He was a thin guy, an attorney, stayed healthy. And back in those days, we thought in manual therapy and Pilates that we're going to correct that curve, right? So here he is, 74 years old, running with no pain. His body had adjusted already to it. He was stable, and there was no movement happening there. And we freed up a little bit of that on the concave side, and we made it so that it was unstable, and he had pain for the rest of his life running, because we didn't understand. I didn't understand. The practitioners I was working with didn't understand that. And that was where we started looking at thinking, like, the body has an incredible way of seeking a balance. So a lot of times when we see these curvature changes or anomalies, we sometimes get too excited about thinking, and you hear this all the time, is like, oh, our Pilates or our chiropractics corrected that spine curve or blah, blah, blah. And, this is a language that we have to avoid. We have to get out of speaking this way. And there are a couple of questions that came up, Hagit, for you, and I don't know if you can see them or not. One of them is talking about after somebody already has had to have the fusion, so somebody with Harrington rods, and maybe you want to address that one.
Is it, which one?
This is Michelle Spinner, said, what about clients with Harrington rods? This is in the Q&A, not the...
Okay.
Yeah, but just asking, what about clients with Harrington rods? And I think they've already been fused, so the fusion has taken place. And any thoughts on fitness with people that have had the fusions?
I want to say, in terms of first know if, I would say, are you good mover or not good mover? If you have the spinal fusion and you good move, because you want to learn to move well. There is generally, once you fused your spine, I remember Dr. Cunningham said, information says, your spine is stronger than my spine. And you can do everything you want. If the fusion took place, which usually adolescent up to 6 months, adult, we give it 2 years just to be safe, then they can do anything they want. They can run, they can horseback riding, they can swim, they can ski, they can do Pilates, yoga, as long as you're not attempting to bend the roads, but they learn it. They learn it from the surgeons. But in terms of respecting the position of the road, anything they are free to do.
Yeah. And the
This
thing
is
that I
by
would add
Dr.
to that,
Leslie and Cunningham.
and the thing I would add to that is just thinking of the segment above and below the fusion, or the joints above and below it, is just thinking of how can I add maybe more movement or strategy that comes from the ribs moving around the fusion, or the segments above in the neck that could minimize the stress of the adjacent joint. You're going to say
Fantastic. Fantastic, Brent. You're a good team worker. Very good that you completed me. So now, of course, it's got to come into details. Where is the fusion? Fusion in the thoracic that left the lumbar. Just be aware of this lumbar, because an adding on phenomena can take place if we don't take care of it. What is to take care of it? As you said, it's the segments below and above the fusion, stability as well, and strength, and positioning, and posture. Every instructor can tell you what to do on a safe way.
Yeah. There was another question that came in. I'm going to postpone this one because it's actually asking for examples of how you work. And Hagit and Lisa have developed a beautiful online course that is asynchronous. So you can go at your own pace and go through it, but really teaching you not only part of the assessment of fitness in Pilates, but also looking at how you would prescribe and sort of develop this idea of stability and then move into movement. And so we could talk about exercises as a whole nother thing, but there is a beautiful course. You can just go to the Polestar website and look up Hagit and Lisa's course. Hagit and Lisa also have other courses they do that are in other movement categories and fitness categories. They really have you become the leaders in the world of understanding how to prescribe movement for individuals with these spinal disorders. So I'm gonna pass on that one. Well, if you're really interested in that, come check that out and take Hagit's course. I've seen it. I think it's beautiful and very clear. As much depth as you could possibly want is going to be in there. Another question that came up, she said, this is Diane Gard. She says, I'm a Schroth certified Pilates trainer. And what she's talking about is some people who are working out in gyrotonic expansion system. And so familiar with both, and just thinking of, again, I think it's not the method that we're talking about as much as it is sort of the idea of stability and then exploring the movement and depending on the markers. Any thoughts on that, of going into something that's a little more aggressive in ranges of motion like gyrotonic or yoga?
Right. We really spoke about it. Actually, my friends, my colleague. So in your mind, stability versus mobility. Who to whom to give what? Gyrotonic have, as you said, more extreme mobility. Pilates is is better. Is better in that terms that you have a variety of exercises and modifications on the equipment and on the ground that you can work exactly as me and Lisa predicted with you working on this course and the analysis of what I just presented. Gyrotonic have a little bit more a free mobility that I am not sure how we can modify it because what is the goal of gyrotonics? I think the goal of gyrotonic is to provide, okay, of course, I believe they will use the word stability too, but it's really to mobilize the joint. So if you can despair the spine and use the extremities, fine. At this moment, I feel a little bit less to guide my patient to go there, especially if they have these modifiers for lumbar instability.
That's what I was going to say, is if they were without modifiers and they had mild, spine disorders, that the idea of distribution of movement equals distribution of force has a lot of application in the gyrotonic environment, teaching them how to move from their thoracic and how to incorporate neuromuscularly the shoulder girdle and the hips and the pelvis with it. You're actually distributing the force and making it so there's less force going through the higher risk joints. And I would say the same thing with yoga. If you're looking for extreme posturing in yoga and you don't have really good distribution of movement, you're always going to default to the weakest link. And a lot of times that weakest link are the transition segments in spine deformities that are going to take the brunt of that force. And that's where we see more degeneration happening there. So again, I'd be careful of black marking any kind of movement, and more importantly, following the guidelines. Like, well, you really need to be more in the stability world with these modifiers and your movement capacity. You're going to be better here. And in the gyrotonic system, we can create stability and we can make that happen. It's not going to be like the full program, but that's the same thing in Pilates, right? We're not going to be making them do the squirrel on the trapeze table, if they're dealing with some severe deformities in their spine, so disordering state.
You know what?
Cool.
It's really, it's a mindset, it's a mindset and understanding. With scoliosis, the spine is shifting, the spine is there are opening of the facet, of the ligaments. The spine, progression of scoliosis is progression of the tissues going into, okay? So do we want to create more laxity, more, or we want to stabilize things? Really, I know I live it. I live LIVE. I live it all the time. So it's easy for me to say it. And I explain to patient the biomechanics. After all, it's their choice. But take time to understand the biomechanics of scoliosis, to accept this modified restriction at times.
And I'm glad you said that too, because one of the things that, the better we understand the biomechanics of disc and facet, and in particular, the uniqueness of the different levels of the spine and the relationship to the segments above and below, even understanding transition joints of how T12 is a really important one, because T11 and T12 act a little bit more like thoracic vertebrae, and then T12 and L1 act more like lumbar. And there are bony changes that allow that to happen. And if we understand that biomechanics and that anatomy, it makes it so much easier for us to see how the movement, the exercise, the stability can play with some of these different anomalies that we see in the spine walking through our door, and also the severity of it. And there was a really good question that came up, Hagit, by Yasmin. And you had made mention that when we see that somebody's sort of in this chronic pain cycle in their fitness and with their spine disorder, to be able to refer them to get a consultation from a medical professional. I think this is the other big responsibility that we have in the fitness world is, we're going to have clients that don't fit into our model. We don't understand enough of the pathology, whatever the pathology is. And maybe talk a little bit about your experience with fitness instructors successfully referring their clients in to get more evaluation, whether it's from a therapist or whether it's from a doctor or a spine specialist. What are your thoughts on that? Maybe elaborate a little bit for them as far as, the success of doing that, of referring.
Right. Good.
While you think about it, we talk about this a lot in looking at our Polestar assessment tool. And this was also something, just FYI, it used to be the Polestar screening, which was started by Lisa Stoltz. So again, Lisa has always been thinking of predictor rules, and her dissertation was in predictor rules. But the idea of having an algorithm that takes you to a point and you're going like, this is out of my scope. this is out of my scope as a professional, fitness professional. This is out of my scope. I need to refer them out. And how do we build this relationship? Like, for example, Pilates teachers and yoga teachers and gym instructors around you that have maybe trained with you, Hagit, what would be your expectation in your relationship with them to refer somebody to you for further evaluation? And we as physios do the same thing. We have some patient that something's outside of our scope and we refer them on to get their imaging or to get blood tests or do things that are outside of our scope. How would you want our Pilates teachers today that are on to work with you or with me as that next level of assessment when we see somebody not responding or in chronic pain?
I think you probably said the answer in the question. It's always good to have on your side, for me as a therapist, a few instructors that, right, first of all, for me, once I finished to teach what I want to teach, then I want them to apply it in movement, in fitness, because physical therapy is more a restrict regimen. And I want them to, yes, be able to enjoy fitness. So I have a bank of Pilates instructors, let's say, and yoga who understand scoliosis, and I refer them out to continue with them. And I feel the same in terms of when a patient don't feel comfortable with their body during the exercise, during the lesson. First, maybe there is something about the type of exercise you chose for them that you think they are good, but maybe they are not so great. And you by yourself, you cannot, you're not comprehending that something about the choice of exercises that you chose maybe are less favorite. So, and it's time they come, let's say you refer them to me and I ask, what do they do? Oh, we hollow the abdomen, we do a lot of pelvic tilt. So immediately, I think I have a little bit of an answer. I don't want you to force to pelvic tilt. Then I contact the Pilates, we speak nicely. Many times I actually come with a presentation with my computer and I explain, so it's good. Let's say the exercises, the regimen is perfect to my eyes as well. But the patient is still in some type of pain. In the spine, we're talking, or radicular pain, because we're talking about the spine, or radicular pain. I can look at imaging. Not always that we know from McKenzie, and we know that not always imaging related to really the source of the pain. But
it's another tool. It's another
right,
tool.
It's another tool. Then maybe you can maybe some. Again, I will go back to the emotional pain, and I hope that you can, as a fitness, that see the client. But if it's in a classroom, so maybe you don't have this one-on-one, and maybe if I have a one-on-one and I'm into understanding the emotional pain more and more by reading, by researching, maybe I can open this tool and give the patient the tool to look at it at this way, treat themselves, find another solution, and go back to the class. So there are so many different aspects on the pain. Maybe I can actually calm them down and say, hey, there is really no correlation between the size of the curve and pain. So if you thought about it, I actually want to calm you down. There is really no correlation. But the doctor told me that scoliosis is my source of pain. They blame the scoliosis. They discover. Let me tell you, and I open and I show them on research, the evolution of research. So it's a harmony between the fitness instructor, what they can provide, what they know, what.
Yeah, I think the important word that you kept saying is the communication between practitioners, and I think that's really the key point. We know that our patients need to have fitness, and we can't always provide the fitness for them as doctors of rehabilitation, and vice versa. That some of our fitness clients need to have more consultation or a higher level of interpretation, and that's communication between us. Hagit, we are at the end of our hour, and it can run so fast, and we could talk for so much longer. There are more
We can
questions
have another
out
one,
there.
right? We can have another
Yes,
one.
yes, absolutely. I want to thank Dr. Hagit Bereshevsky for joining us today. Thank you so much, Hagit. And I hope that you can appreciate, just in the short hour that we've been together, the depth that she brings into the wellness and fitness industry regarding spine disorders. And I would say that please, we'll always put it into the post-production, that you'll have the links to check out and evaluate a little bit more of Hagit and Lisa's course. But I would strongly encourage you that every Pilates, yoga, gyrotonic, Feldenkrais practitioner, we're all going to have somebody come in that has a spine disorder. And the idea of really understanding what is important for us to know, and what kind of modifications we would make, and how do we make these decisions. Those are things that are discussed in their courses that are very empowering, and going through repertoire and being able to understand and see it in the videos of working with the exercise apparatus and the home exercises. So do take advantage of that. I can't emphasize this course enough for you.
Thank you so much.
Hagit, congratulations on the paper, and we'll be looking for it when a publisher picks it up, a journal picks it up. So it's going to be a great contribution to the fitness world. And kudos to you again. You have some messages coming to you in Hebrew, I see, on the Q&A. I would interpret it for you, but my Hebrew is not so good. But wishing you the very best. Thank you again, and wishing everybody in the world one concept of be kind, and know that our vision is to bring the world physical, emotional, and spiritual alignment, which the work of Dr. Hagit Bereshevsky is in complete alignment with. And we thank you and Lisa for your hard work and all you contribute to the world of movement. So thank you, everybody. Have a wonderful weekend. Hagit, love you. Take care.
Love you too.